I'm Dr. Prakken. Glad to have all of you on board, as we said before. Again, we've got a nice little crowd tonight, and happy that you're all here. As a way of brief introduction, I am the chief of the Avance Medical Pain Clinic. I spent about 7 or 8 years at Duke doing the same kind of thing and decided to come back into private practice. Our treatment style is that of both psychiatry and pain, where I'm double boarded in both of those entities, both psychiatry and pain, which helps incredibly with chronic pain patients because that combination is something that really permits you to not only just understand the pain condition, but also understand the dynamics that kind of happen because of what happens with pain. And that is, again, just an incredibly helpful treatment modality. So let's get on with the slides. And I've got about 4 minutes of information. Then we'll do Q&A afterwards. I will go through the chat list at the end of the slides and answer questions. We'll have kind of a more dynamic process at that point. But again, happy to take any questions. And again, if you can't hold on to your question for now, go ahead and put it in chat and we'll talk about it in just a few minutes. Okay, so objectives. What we're going to learn is definitions and types of pain and be able to identify kind of all the misunderstandings that occur regarding risks of pain management and how those misunderstandings are formed, and also understand kind of a more accurate profile of what pain patients and pain management is really like. And then also learned about some treatment and how we do that in kind of a patient-focused way. First of all, kind of a simple, easy definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And again, this is a very intellectual, academic kind of definition, which is good for research, et cetera. But the reality is, essentially, this is the reality. This is what happens with pain patients. Sometimes the practitioners also get frustrated, but pain patients are in a horrible, horrible dilemma. That's primarily because, again, the somatic reality of pain, it is the only medical disease that has the ability to send a constant aversive message that your body is being damaged or harmed. Cancer doesn't do that unless there's pain. Hypertension does not do that. Diabetes does not do that. No other disease process is a constant aversive message, right? And also with pain, it is persistent. It is intrusive. It pushes itself into your life. It makes behavior change on a moment-to-moment basis that is unavoidable because of the pain itself, right? And that is an enormous issue. It's also self-perpetuating and self-enhancing, and we can get into all sorts of conversations about that. But again, it's a major problem in how pain even reproduces itself. What kind of pain is there? As you can see off to the left-hand side, the little arrow says nociceptive pain. Nociceptive pain, briefly, is the pain that comes from everything being normal, right? So it's hit your finger with a hammer kind of pain. It's kind of pain that all the wires are intact. There's no odd things in the background, et cetera. And as you can see, it's most classic common types of pain: osteoarthritis, rheumatoid arthritis, say tendonitis, a neck or back pain with structural pathology, et cetera, et cetera. That's everything's working normal, no problem. On the right-hand side, you see the little Venn diagram down there. It says it's neuropathic pain. What that means is the nerve itself is damaged in some way and somewhere along its route. Neuropathic pain is actually pretty darn common, a little bit harder to treat and sometimes a little bit more tricky to diagnose. And it comes along with postherpetic neuralgia, diabetic peripheral neuropathy, which is people that have diabetes have a burning and tingling of their extremities many times. Spinal cord injury, something called small fiber neuropathy, again, which is a very, very common neuropathy, multiple sclerosis, et cetera. These are neuropathic pains. The nerve is the pathology causing the pain. And then there's sensory hypersensitivity, which is the upper part. And I call that actually central sensitization. And that is where the brain itself, and sometimes the spinal cord, is activated beyond normal, so that every little bit of pain input is expanded upon. And this is not a sensitive kind of thing. It's not a mood thing. It's not an emotional reaction. It is actually a neurologic enhancement of pain sensation that occurs in people like, as you can see, fibromyalgia, irritable bowel syndrome, interstitial cystitis. Sometimes, commonly with the other nociceptive pain or neuropathic pain, you also get this central sensitization phenomenon that comes along with it. And so you can have that in neck and back pain, or TMJ, headaches, et cetera, et cetera. The trick is, just like this diagram shows, there's a lot of overlap. So people can have a nociceptive pain with a neuropathic pain and a sensitization pain all at the same time, many times from the same region, which makes pain at times really difficult to treat, but also difficult to diagnose, and not something that you just want to kind of, as a practitioner, put all in one bucket and say it has to be just this one kind of pain. If you have other things going on that I don't understand as a practitioner, this must be, odd, or you're, somebody that I don't understand, et cetera. That's easy to do as a practitioner. But if you really understand what pain's about, you understand that this can actually have a lot of overlap and can look very confusing. So let's look at some common beliefs about chronic pain management and chronic pain that are actually not true. Number one is, you hear a lot that opioids don't help pain. It's a kind of common cultural or academic kind of belief now. And it's very true that the long-term studies are poor, but the trick is the long-term studies are poor in every pain option that we have. And it actually has, opioids have the same benefit as any other pain treatment, or if we can actually say other pain treatments don't have any better benefit than opioids. High-dose opioids should not be used. And we worry about addiction and death in that, and we'll talk about that in a little bit of detail. But essentially, the overdose rate is in people that are taking pain, they're taking opioids for pain management. They, again, don't have a overdose rate that is enormous because of a really high dose. The maximum or the most common overdose is under 90 milliequivalents of morphine. And that's a level that the CDC kind of didn't mean to, but they did set in 2016, and has been driving down people's practitioners' use of pain meds of the opioid type since then, out of fear that there's going to be some kind of legal ramifications. And some of the belief behind that is, if you're over 90, you're going to have people at increased risk, when the reality is under 90 is still where the highest risk lives. Most of the ODs occur under 90 milligrams of morphine. The other thing is that the death by suicide is 7 times that of death by OD in pain patients. In other words, if you're looking for some thing to be concerned about as a pain practitioner, and again, we're talking about opioids for now, but if you're worried about giving medications to people, the reality is people are 7 times more likely to die from overdose than they are from the medications if you're a pain patient. And that's where the focus, I think, should be. Addiction in pain clinics is high. Again, this is another belief that's not true. The addiction rate in pain clinics is about the same as it is in the general population, same as it is in primary care clinics. And also, opioids commonly cause addiction. The chance of addiction starting in pain management is about the same as the background, 0.07 to 7%. It's not that suddenly that people in pain clinics are being addicted by just the use of opioids more than kind of a natural occurrence. Everyone should be tapered off of opioids. The reality in our clinic and some clinics is that, if we can keep people safe, we will. We'll do everything we can to avoid opioids, but at the end of the day, function is the goal. That's the thing that really dictates treatment, not a certain medication, not a certain milligram. It's actually, how do we help with function? Because that becomes for us, the primary goal. There has been a lot of talk about getting people tapered off opioids because of tapering studies. But the trick is, those tapering studies actually been somewhat misleading. Most of them having to do with people that were actually volunteers, not kind of a normal opioid group, nor a normal pain group. And they were saying that in some of the studies, people do better off of opioids. That has not been really well documented in people that are not volunteering. There was a VA study that came out that there was a 6-fold increase in successful suicide in the people that were kind of mandated to taper opioids. And again, another belief is opioid side effects are too dangerous. Dose change is the highest risk. Fatigue, cognitive impairment is commonly due to pain itself, not necessarily opioids. Pain meds are the reason for the opioid crisis. Actually, there was a 3-stage event of the opioid crisis, which is still ongoing. The first stage certainly did have to do with pain medicine. The second stage had to do with increased concentration and purity of heroin. And the third stage, which has been since 2014 now for the last 10 years, has been fentanyl, and very little to do with any kind of pain medication. And again, prescriptions and the amount of pain medication being given in the country has been dropping since 2010, and the death rate continues to climb. Misuse of opioids is a clear sign of addiction. It's not true. About 3.7 people misuse opioids, which is decreasing. And the trick is 85% of the people that are misusing opioids report that it is for pain, tension, sleep, or mood, things that we would want to treat anyway. It's not for getting high. It's not for playing with their pills. It really is for something they want to try to do to increase their function. Another thing is never go over the CDC guidelines, but those guidelines actually had very low quality evidence. And since then, the CDC has revised their guidelines to really kind of turn down some of their most difficult guidelines that came out in 2016, again, saying this should not be used for standard practice, that people should not be tapered by themselves off of opioids without kind of a collaborative affiliation with the docs, et cetera, et cetera. So it's come out with new guidelines, but most people have not necessarily paid a lot of attention to that. And again, in opioid pain patients, death from suicide is 5 to 7 times greater than that of overdose. Opioids don't work, other treatments are better. The long-term evidence is inconclusive for all treatments. Essentially, pain is really, really hard to treat. Opioids and adjunctives like gabapentin or Lyrica and behavioral treatments like CBC, people getting cognitive behavioral treatment. All those studies show some benefit in some individuals. But there's no one better treatment in terms of long-term outcomes. Cancer pain, even though it kind of is something that people believe more in, there's no evidence that it's any different than chronic pain in terms of the outcomes, in terms of treatment. Behavioral treatments, really, really important. You really do need to do as much cognitive behavioral CBT therapy as possible. And again, the evidence is pretty good, but the effect size, how much it really changes people is not actually pretty small. And most of the studies were done in people that did not have depression or did not have anxiety, even though that's the vast majority of people that are pain patients. So we have to be a little careful about believing that behavioral therapies, which are incredibly important, do need to happen, and we try to have them happen as much as possible. They're not a panacea. Opioids just make you tired and dopey. Actually, about at least 25% of the people taking oxycodone are literally stimulated by opioids. It's actually a common issue having to do with people that may move more into misuse. You have to be careful because some people are stimulated and really like that. And again, cancer pain is different. Again, there's no better data for cancer pain than there is for chronic pain in terms of efficacy studies. And there's a lot of increase in chronic pain in cancer. So we have to be careful about making those kinds of distinctions. So with all these kind of, in some ways, I would call them fallacies that people really believe is true about pain management, especially about opioids, how do we end up with these beliefs? Because they're really not accurate. How do we end up with all this? What it comes down to many times is that the culture, and many people really believe that at the end of the day, behavior is always a choice, right? That's a belief. And there's a lot of feeling about that and evidence for that. But the trick is, it's not necessarily quite as easy as that. So if it's really a choice, right, just stop it. Stop your pain behaviors, stop complaining about your pain, stop having impulsive medication use, but also you'd have to then say, just stop being anxious, or stop being depressed, or stop having an addiction, or stop eating too much, et cetera, et cetera. If behaviors are just choice, you should be able to just stop all those things, right? And many people will say, especially with pain management or other medication or addiction, or sometimes even, mood problems, since I can control it, then you can too. In other words, if I can, why can't you? Be like me, it's easy, right? But the trick is each one of us is better at controlling different things. Some people have an easy time controlling what they use for intake. Some people don't have an easy time with eating in a way that keeps them the most healthy. Other people have a really easy time with having a few drinks of alcohol, and other people just get out of control with alcohol. Each person has a capacity to be in control of things that somebody else doesn't, and it's very personal and specific. And again, this works in relationships. This works in coffee, food, addiction, etc. One of the things I kind of use as kind of a classic example of this is, if I'm doing this in a large group, I would say, everybody, most people, probably many people online right now have had a long-term relationship, right? And I would ask the question, in that long-term relationship, how many people have had an argument? And I would ask people to raise their hands, and like 95% of the people raise their hands, as they should. And I would say, okay, how many of you have actually contributed to those arguments? And I would say, keep your hands up, because everybody in a relationship will have some contribution to the arguments. And then I would ask the simple question of, if in a good long-term relationship, you have tried to actually manage those arguments and you have had conversations about them, have tried to change, how many of you have been able to profoundly change the chronic type of arguments you have in a long-term relationship? It's not that easy. It's not that simple to change behavior. And using such a simple kind of personal example as a way to say, if I can control that particular irritability on my part in a relationship, why can't you? Because everybody has their own kind of reality. So behavior is really something that's very, very persistent. Personality, which drives most behavior, is an operating system. Think about it as a computer. It's the foundational operating system of how you approach the world. It's incredibly necessary. Again, it's foundational, and also lets you have a really rapid response. And that is very helpful, especially where we come from, hundreds of thousands of years. It'll keep you from being eaten by the saber-toothed tiger, because you're going to make a really rapid decision. And we all have different personality types. Some are distant or demanding or anxious, and there's lots of different ways we can talk about those personality types, which are very common in humans. And again, mood is a product of the operating system, and so anxiety is, mood is, impulsivity is, etc. It's not something that can be easily changed. And the treatment then, just like pain, it can only be partially effective. You can't change somebody's personality with treatment, and so there has to be some amount of flexibility and understanding. And this goes on, like for assumption formation. Since I can control my impulsivity or my behavior, right? And I'm obviously normal, right? And you can't, then you must be what? An addict or lazy or incapable or not motivated. I mean, there's going to be a judgment that ends up coming from that. Since you're not able to change your behavior and I don't do what you do and I can control it, then you must be something, right? So it's your fault. You need to change, not me. It's forms stigma. Again, the kind of a shunning that occurs. And this happens with people that have chronic pain. This happens with people that have substance use disorder, and all sorts of things. And again, these assumptions dominate people's thinking, right? Our minds don't like to have open-ended questions about other people or situations. We really want answers. And what we do is we fill in those answers with our own personality. If I'm a judgmental person, I'll be very judgmental. If I'm an anxious person, I'll fill it in with concerns and anxiety about how the person's seeing me, et cetera, et cetera. We all add into these unanswered questions about other people. We add our personality to that. And we call that transference in the psychiatric world. It's how you kind of transfer your own beliefs and personality onto somebody else in your hope for understanding them when you don't have all the information that you need. And that's where, again, a lot of judgment comes. Occurs with individuals, institutions, et cetera. And danger, and the idea of danger is actually the most important of these assumptions, because we, again, need to make sure that we survive. We need to live. And so we're going to over emphasize things that may be dangerous. So many assumptions will be negative. In other words, I need to protect myself from these things about you that I don't know. So I'm going to make assumptions about them that leave me feeling anxious, or that you're a danger to me, or even yourself at times. But I'm going to be very careful with that, and danger is going to be the most important piece. So I'm going to have more of a negative response and a positive response. And that's just very normal in relationships and normal in medicine. And again, they're very reflexive and unconscious. And many times we don't kind of question those assumptions, because we need to have that to be something that gives us, again, that rapid response. We can't stop and think about every person that we see. We have to make assumptions. So the reality is, what are pain patients, what's their reality in truth, right? Pain patients are depressed, right? Chronic pain is a horrible condition. It is, again, just so what I call corrosive, that the depression is 30 to 50 at least % of the people that are in pain. And I'm not talking about a bad day. I mean, chronic pain really begets major depressive disorder. And up to 80% of people in chronic pain have a major depressive disorder. And again, much higher suicidal thought and rate. Anxiety also very high. 16 to 50% of people in chronic pain have anxiety disorders. Pain and substance use, 30 to 60% of people with opioid addiction have a pain condition. So there's some, there needs to be some kind of understanding that many people that are diagnosed with an opioid addiction actually have a pain condition, and there may very well be overdosed. I mean, overdiagnosed. So many times in a clinic, somebody who's in a pain clinic that has some impulsivity, and that's just part of their personality. They're using pain meds, and sometimes they overuse them because they're hurting. And again, overuse is usually 85% of it is something that we would want to treat anyway, remember? But many of the docs will say, oh my gosh, you're misusing the meds. I've asked you not to. I'm not really thinking about impulsivity. It must be addiction. And the reality is, no, it's not addiction. But now suddenly these people are called addicts, and they're sent off to be in methadone clinics or buprenorphine clinics, and that's better than having nothing for pain. But it's not uncommon that I find people that are long-term diagnosed with substance use disorder that actually are a pain patient that didn't have any good options for treatment. And I think it's quite a large number. And also ADHD. It's really shocking and surprising that 45% of the people with fibromyalgia have ADHD. We don't really know exactly why that kind of correlation occurs. But it's really common, and up to 80% with anxiety. And again, they tend to be more impulsive then. So many people in chronic pain are actually suffering from addiction. Baseline in 2020, 15% of the people older than 12 had at least one use disorder. 7% of the population had an illicit use disorder. That was non-alcohol. Most of use disorder is alcohol. Pain in primary care, though, again, 8 to 12% of the people have a use disorder. So it's not really much larger at all in pain treatment that people have addiction. It's a fallacy. And again, what happens in pain clinics where there's not a whole lot of psychiatry, it's very common to have pain patients that happen to be impulsive or struggling with mood be given the diagnosis of use disorder. And I think I would submit unfairly. So use disorder has a definition. It's not a gut check. You can't, see somebody coming in with multiple tattoos and piercings and asking for some pain treatment to call them an addict. You have to have a criteria, and you have to document what that is. And do urine drug screens, and make sure you're checking what they're getting from other practitioners, et cetera. And if you're unsure as a practitioner, ask somebody else in the house, what's their use like, and check the risk factors that come from their genetics and the family. And remember, again, misuse is not an addiction issue. What is the definition of addiction? So the most important ones, actually, these are tolerance withdrawal, or something that is just common with using any kind of opioids. Impaired control is where I start thinking about, gee, is the person I'm seeing really somebody who's struggling with addiction, or is this just a pain condition that's not being fully treated? If they have impaired control and are using more than they want to use, and are craving the substance, not craving pain control, but craving the substance, that gets my attention. In particular, I start looking at role failure. Is the person I'm seeing that I'm a little bit worried about, maybe they're somebody who's suffering from addiction or not, is their life coming apart because of the pain medicines, or is their life coming apart because of pain? And many times I will treat somebody with medication and find them actually having increased social capacity, no longer having role failure, increasing their kind of social contacts, and the family starts becoming more normalized again as we treat, not as we reduce them in terms of medication. And again, it comes as mild, moderate, and severe. A very common place, I think, for pain clinics to get confused is what actually is addiction and what is not. So impulsivity, very, very common thing. And especially if people that have pain that is out of control, they're going to be more impulsive. And it's a very common reason for medication misuse. And again, people that are impulsive tend to make decisions out of kind of an emotional state, which is very understandable, especially when you have a pain condition. The trick is practitioners think that, that these people are not necessarily telling the truth. So how this comes about is, you're sitting in a pain clinic and you've had the conversation with a patient about medication use, and you would find that, gosh, the person's like 4 or 5 days short on their medications for the second time. You have a conversation with them, you talk with them and warn them, please, you can't do that anymore. They say, I'll never misuse my medications again. You come back the next month and they're again short. Many practitioners would then kind of think, oh my gosh, you're lying to me. You're trying to mislead me, et cetera. And the reality is that's not the case. When the patient talked to you as a practitioner, when the patient talked to you, they were completely telling you the truth. They really thought and wanted to not overuse their meds. But when they get home and they have pain that's out of control, in that emotional state, that new state, they're going to make a different decision. They're not going to be able to maintain their capacity to take these meds in a very, very specific, concrete way, because they have a different need, a different emotional state, and they're going to change their use. They're going to be impulsive in their use. It's not addiction. It's not something that they're doing for known self-harm. It's not something they're doing that's going to cause social deterioration. If it does, that's a different story. But most people are, if they're impulsive, are doing it to try to manage another set of symptoms that we as practitioners need to be curious about. And if you're curious about it, that really changes how well you can actually treat folks. And again, it's very predictable. You don't have to be, barking at patients because they're being impulsive. You have to predict it and help them contain it. And what do you do with that? You get curious about, why they're doing it in the first place. You really ask the question. When you're taking the extra pill, what were you thinking? What was going on? Not give them a lecture about taking the extra pill, because it's going to happen. And that's just normal. And again, you're going to see people are anxious when they take it, or they have more pain, et cetera, et cetera. We need to be clear about why they are actually doing that. And again, you can help out and give them kind of tools for that, like having somebody in the family give them the meds, so they have to check with another person, or give them a week of scripts rather than a month of scripts, so that they can't be short and maybe even withdrawal at the end of a month if you gave them those scripts, et cetera. There's ways to work with that. So in our clinic, so then how do we treat pain patients in our clinic? What do we actually do? Right. The first thing that I teach my PAs, and how I approach this, is I have to remember the person sitting in front of me is currently in chronic unremitting pain. Right. They are not pain-free. They are in a place where they're having intrusive pain all the time. And that's what's sitting in front of me right now. They have a particular personality. I'm not going to be able to change that. I don't even have to change it. It makes it predictable. And there's ways I can sort that out with the person, especially having psychiatry as a background is very helpful to kind of sort that out on the front side. And so that you can have a clear conversation about what may be coming up as you approach treatment. And it can be very helpful to know that I'm not going to try to change things. I'm going to try to figure out what it is that we can do to help the parts of your personality that are going to potentially be problematic. And also the person sitting in front of me, right, they know that there's a cultural bias. The pain patient walks in anxious, knowing that this is not an easy thing to do. I need to talk to another doc about my pain condition. And so people are going to be defensive from the start. That's going to be normal. And having a practitioner be concerned about them seeming defensive is like, well, you would also be defensive. So, be understanding about that. And patients may emphasize their condition or say pain is always 10 over 10. How I interpret that is, you're essentially yelling at me, and I'm fine with this, is what I say. You don't have to convince me that you have pain. You have pain. And telling me that it's 10 over 10 all the time is kind of how I take it, is kind of a scream for help. And I'm here to help. I'm not gonna say you don't have pain. I'm not gonna call it a psychiatric issue. We're going to try to figure out what it is and how to treat it and how to get you to be the most functional you possibly can. And just know that as a practitioner, that this is how it starts. And it's very normal, because people are going to be anxious and worried as they come in as a new patient to a new practitioner. And also, as practitioners, we have our own personalities. We have to be alert to that. We have to be careful of our own biases, and make sure that we're doing things that are by the rules and diagnostic criteria, not some gut check, especially about use disorder or addiction. So our clinical approach, again, we are curious. We don't need to be authoritarian. We're curious. I want the patients to teach me why they use meds the way they do. I want them to teach me what their pain is. I want them to teach me how they're feeling in the middle of the night when things are not going well. I want to hear what's going on, because only when I can hear those things, then I can actually be of use. I can then help, right? And if somebody is struggling with being short on meds, as a classic example, that is kind of a normal thing. And I want to have that actually be normalized. And so people don't have to feel defensive or not tell me the truth, right? Or try to hide it from me, because then if they hide it from me, I can't help. And so many of my conversations are, what you're doing is completely natural and normal. This is not a problem. I don't fire people from the clinic for this. We just have conversations and try to figure out what's going on. Because if I can understand why you make the decisions you make, then I can actually help. And that's what I'm shooting for all the time. And again, the decision making is collaborative. We called it shared decision making. There's a lot of research on it. And that's what we do. Sometimes if somebody is really putting themselves in danger, we may have to make a unilateral decision, but that's also still a conversation. None of this is done with a surprise or a agenda on our part to make sure things look a certain way. It's really like, how can we help you function? And this particular path we're taking now does not look functional, so we probably have to change direction, but it's a conversation, right? And we have clear and predictable limits. There's no surprises. We don't suddenly jump up and say, well, you've gone too far and we're upset with you now, and why did you do that? We don't do that. It's again, something that we get just much more collaborative about. And bilateral transparency, we will tell people exactly what kind of limits we have and what our concerns are. And we have that be also what we ask of the patients. Tell us what's going on. Make sure you let us know as much as possible about things, even that you're embarrassed or afraid of telling us, because if you do, then we can help, which ends up being the most helpful approach that I can possibly imagine. And when you're trying to treat something as difficult as chronic pain. And again, don't teach us that you aren't truthful, right? Just be truthful and let us know, and then we can go forward. So the primary thing for us also is that function is the goal. Function, not necessarily just pain reduction. It is really about function. So we try to figure out what is the thing that's most in the way, okay? Is it pain? And we can only help 30 to 50%, can't make chronic pain stop. It just doesn't happen. We can get maybe 50% done. So is pain the most in the way? Is mood the most in the way? Low energy cognition issue? Is a substance use disorder most in the way? Right? We can treat that at the same time as the pain many times. And we focus on one thing at a time, utilizing our training in pain and psychiatry to take the clarity that we have about what the most important and functional hurdle is, and going after that with whatever modality we feel like we need to try to help people be functional. And that's the most important things. And sometimes medications are the cause. We can have like an oxycodone that's too stimulating and the person can't sleep and they get irritable, and that becomes a problem. So we need to change out of there. Or gabapentin has made somebody too tired and they feel like they're sleeping all day long and they're cognitively impaired, and everybody thinks, they're manifesting addictive behaviors, when in reality they're just tired on gabapentin all the time. There's all sorts of things that we get into, especially with medications, that we try to sort out. And each medicine we look at is kind of a cost benefit analysis, because none of them are going to cure chronic pain. It's going to be just helping with function. And if the medication happens to make you less functional, then we don't use it. If we do a trial of trying to test whether the medication you're taking is a problem, we go lower and your function gets worse, then we go back on the medication you were on. It's not like we have a dog in the race to make sure that you have certain medications at certain doses. We're trying to figure out what helps. And there's no specific med limits. We certainly look for function, obviously, but also for safety, and it's all collaborative. And do we feel like sometimes we need to send people out for surgery, injections, et cetera? Absolutely, and we do that readily. Last slide, very quickly, like what about surgery? When did you do that? Many people will talk about back pain, and they want to get an MRI to get surgery. The trick is, if you don't have a neuropathic condition, if you don't have nerve pain along with your back pain, nobody should be doing surgery, because as you can see, if you do back surgery for just pain, 30% of the people may get better, which does not mean no pain. It just means improved by 2 to 3 points on a pain scale, or they'll stay same, or they'll get worse. So the vast majority of people get no better or worse if you have surgery for pain alone. If you have neurological problems like a leg weakness or numbness, that changes the thing. If it has nerve symptoms, then you get an MRI, you do nerve testing, you get a surgical consult. Joint pain and surgery, if you have something that's red, warm, and swollen, then get a surgical evaluation. If it's painful and there's a recent injury, get an evaluation. If there's no injury and you have a painful joint, most of the time it's going to be wait and watch and see what happens. That's kind of a rough quickie about surgical thoughts. So this is our contact information. I hope this has been somewhat helpful. And so you're going to have to go into the Q&A tab, question and answer tab, and put a question in there. They're saying that chat is disabled, and that's really unhelpful. I'm so sorry. So there is a question of, are there other ways to manage pain outside of medication? Yeah, there are a boatload of ways to try to manage pain outside of medication. Today, I was going over the stuff that I think people find the most controversial, which is why I focused on that. But the kind of non-medication ways are certainly a exercise program, an ongoing exercise program, especially for back pain, that have you actually enhance your core strength. And again, core strength, everybody talks about core strength. And that's, can be kind of irritating or boring after a period of time, actually. It can be actually irritating or boring after a period of time. But core strength is not just your abdominals, but it's your pelvic floor also, where you actually need to exercise the muscles that actually are included in Kegel exercises, and also something called a multifidus. It's a multifidus muscle that is a classic thing for poor back muscle strength. You can go online and find all sorts of exercises for that. And if you do about 10 minutes of those a day and focus on having your pelvic floor a little bit tight all the time, especially when you're going upstairs or bending over, et cetera, goes an enormous distance for actually helping with low back pain. For other pains and joint issues, having some kind of ongoing muscular tone is incredibly important. So we're doing things as simple as walking. I have many patients that can walk 15, 20 minutes and that's it, right? Because they're in such pain. Well, then I would have you walk 15 to 20 minutes 2 or 3 times a day to try to maintain that kind of capacity. Other things outside of medication are acupuncture and for pain control, acupuncture, meditation, over-the-counter meds if you want. There's all sorts of online protocols and options for mindfulness activities. Again, CBT is a common thing, cognitive behavioral therapy, which can also be of benefit and help. So there's lots of different modalities. What do you know and think of the latest cure for pain that I hear about on the radio? QC kinetics, non-surgical regenerative treatment care. I think if I remember correctly, that is a PRP essentially. So what does that mean? It's where you take blood from someone, you spin it down, you take a certain piece of that fraction of blood that's got a bunch of white blood cells and other what they call pro-inflammatory elements. So you draw that off and inject it into the place that works the best, inject it into a knee joint or a hip joint or even a finger. But you have to have some cartilage left. and that'll actually cause an increased inflammatory response. And so this does not feel good for the first week, right? This is like somebody giving you kind of an arthritis for a period of time, but that then pulls in the body's ability to, with that inflammatory response, pulls in the body's ability to heal and be regenerative. There has not been a lot of literature or good studies on back disc for that. There's some, but it's a little bit trickier. And also, you want to make sure about how much of an inflammatory response you generate inside a disc that may leak with a spinal cord right behind it. So you want to be careful about that. But for large joints, even small joints, PRP can be incredibly helpful, just not cheap. It's like $1,000 per treatment. But it can be really helpful. And I think that's pretty much what QC Kinetics is doing. Another question, back pain from spondylolisthesis, other than surgery, what can help? Mobility limited due to spondylolisthesis. Again, the best thing you can do for a axial issue is have as much tone and strength around the site as possible. And for many people with the listhesis, you end up having a level of laxity in between the two discs, where one disc may actually kind of fall off another disc. That's hard to maintain. The ligaments get really loose, hard to get a ligament to be stronger. What you need is increased muscle tone around that whole structure to try to keep it more contained. The thing about that listhesis is, in terms of a surgical intervention, even though I said just for pain, you don't want to do surgery, listhesis is one of the areas where if you have some mild to moderate neurologic issues, but you do have a listhesis, then you've got like a grade 3, like pretty falling off quite a bit. That can actually be incredibly helpful with a surgical intervention. Other thing you can do for listhesis is do epidurals, which can take care of some of the pain in the structures around that place in your disc area that's causing the pain, and that can be of benefit also. So that's another option. But the biggest, most important thing is really high tone of the muscles around the area. Have you found hypnosis can help with pain to maybe dial it down, and that sometimes pain could be related to past trauma? I did hypnosis for with patients for 5, 6 years, 7 years, actually when I was in California. Hypnosis is incredibly powerful. Hypnosis is incredibly important. But what I found is that usually after 3 to 5 days, it doesn't stick. You learn through hypnosis the skill of relaxation, and that is incredibly helpful. But for a chronic condition, to be able to walk around in a meditative state or walk around in a hypnotic state all the time, which is when pain is around, is all the time, becomes really, really difficult. So can hypnosis and imagery and relaxation techniques be incredibly helpful for the worst moments of pain in the middle of the night or the day, et cetera? Absolutely. And being able to actually have those kind of skills, very, very important. But it's not something that's going to help all the time with chronic pain. It's just going to be one of the tools you have in your kit that can be very, very helpful. Nerve stimulators. Another question about nerve stimulators. Usually that's spinal cord stimulator. And there can be also peripheral stimulators. So most of you heard about TENS units. So this is where a little bit of electrical current is generated. And for TENS units, they put it through an area of your tissue, like on your back or on an arm, where that electrical current kind of goes through the muscle and has an effect in terms of relaxation or pain control. Spinal cord stimulators are kind of like a TENS unit for the spinal cord. And so you will surgically implant a little lead that's about half the diameter of your finger. That lead will be laid down in a couple spots along your spinal cord. An electrical current will be put into that, and it'll essentially, think about it as scrambling the pain message coming from below that spinal cord stimulator lead. And so you can have people with really bad leg pain, neuropathic pain in their legs that's really hideous, no surgical options. You put a spinal cord stimulator in, and that can really reduce the amount of pain coming all the way up the cord and into the brain and received, reduce it substantially. There's lots of different stimulator types, and they can be really helpful. Sometimes they don't do quite as well as you would like after 3 to 5 years, but still it can be really helpful. And I would have you, talk to a interventional person about that. And we're happy to help do referrals for that kind of thing. Get a comment says, I've tried acupuncture, spinal decompression, steroid injection to no avail. Yes, I'm really sorry. That's the whole thing. Sometimes, first of all, even surgery for a condition, a pain condition that is spinal or even joint based, even if it has a neurological component and it's appropriate to do the surgery, it doesn't mean that you're going to have no pain. Sometimes chronic pain is almost impossible to get rid of, even when you have a really good surgical option. And chronic pain is just present. And when somebody has had surgeries or different procedures or injections or spinal cord stimulators or whatever, sometimes we're still stuck. And we do whatever we can to help the person function. And again, assuming that we're going to get 20, maybe 30, really lucky 50% of pain gone, and that's it. And the rest of it is management, containment, and enhancing function. And there's lots of different ways to do that. Even though we can't stop pain, we can give people a life that they want to live. It may not be exactly the life they wanted, but we can give a life that they want to live and be quite productive and happy, actually. I've got a note here that says, in which city are we located? Right now, we are in Chapel Hill, in the Meadowmont area, and easy access. We also do telehealth for people. And if you want to have a referral, you can just give that number a call. That is at the very last slide. And see if I can actually do that. Was here. So this is the phone number. And again, you can also call Stephen Prakken is not a common name. So if you look up Prakken MD, it's going to be the only one in the state. And so it'll make it clear, but it's through Avance Psychiatry, because that's kind of my sponsor at this point, is the psychiatric part of Avance Healthcare, even though we're doing the medical pain work. Ourselves, we're doing all the pharmacology. We have therapists through Avance. We've got a whole host of therapists that do a really, really good job. Groups for pain management. We're doing ketamine infusions and nasal ketamine for depression and mood, and also it can be very helpful for pain at times. And we're more than happy to manage people and send them off also if we need to for surgery, etc. We're happy to help in any way we can. Are there any more questions? Because we're getting towards, we got a few minutes left. If people have any more questions, feel free to put it in the Q&A. Let me look through the Q&A to make sure I haven't missed anything. I don't see anything so far. So I'll leave this slide up for a little few minutes. I will be here for another 5 minutes or so. If anybody has any questions, please just put them in the Q&A slot, and I will take a look at them and answer them. And again, if you have any questions at a later date that you want to ask, give a call. We're happy to help out in any way that we can. At this point, I'm getting mostly thank yous for the presentation, and I would just say to all of you, thank you for participating. And again, let us know if we can be of help, and we'll be signing off now. Have a good night.